Good morning, everyone. Welcome from all around the world for our monthly Peripheral Interventions live case webcast. And I'm Karthik Guja, Associate Director for the Endovascular Program here at Mount Sinai, and we are here for our new academic year, the first live case webcast in the new academic year, where Dr. Krishna and his team have brought in exciting case for us to start with for the new academic year for people watching all around the world. You can see our previous live cases being archived in peripheраlinterventions.org, and go live there and ask us any questions if you have. Before we go to the cath lab, the next live case webcast is going to be August 28th, the Wednesday, at 8 a.m. Eastern Standard Time in New York. And then without any further delay, we'll move on to the cath lab to welcome Dr. Krishnan and his team. Dr. Krishnan, Dr. Kapoor, how are you? Good morning.
Welcome, Karthik. It's good to see you. And we were just commenting on how you look like an ESPN broadcaster. I'm sure everybody's going to love your new look. But anyway, welcome to everyone. We're here, and it's really wonderful to be here in the new year. And we had a great last year with 12 interesting cases that was well received. And we kick off the new year of peripheral interventions, live peripheral interventions. First of all, before we start, I'd like to thank everyone who has contributed to this over the last year, and especially the companies whose, how can you say, unbridled support of our educational initiatives are very well appreciated. But I'm very happy today to start because we have, our entire team together. Yourself, obviously, we have Vishal Kapoor, who's our Director of Endovascular Intervention at St. Luke's, our Director of Cardiology, who's also an interventional specialist at Mount Sinai Queens, Dr. Atul Kukar, I would say our older fellow now, Dr. Sardar Farhan, who's been here now for the last 6 months and who's really ready already to be an attending and take over. Ray Lascano behind me, who's always been here with us to support us. Marichu Malloy, and we miss Elizabeth, who's home in Florida. But we want to welcome our new fellow, Dr. Cameron, who's here, who's actually doing the venous side today. But then we have Damien Cabrera, our tech here. We have a really super case for you that I think will illustrate a lot of teaching points. And I'm going to go ahead and have Dr. Farhan go ahead and present the case, and we'll get started.
Okay, we are ready for the slide presentation. So our patient is a 71-year-old female patient. She's active smoker, and she has hypertension and hyperlipidemia. She presents to Dr. Kukar's clinic with left lower extremity claudication, mainly on the thigh and calf, but also on the buttock, with deemed in Rutherford class 3. She is on aspirin and atorvastatin and lisinopril treatment. And if we see the next slide, she has underwent some non-invasive imaging with a duplex showing blunted waveforms in the external iliac artery, indicating occlusion or a severe stenosis. And then she underwent a CT-angiogram, and I depicted here a picture from the CT-angiogram showing that there is a left common iliac artery CTO with stenosis in the external iliac artery with some calcification of the external iliac artery. And now I'm going to give back to Dr. Krishna.
So this is a great case, Dr. Kukar. I mean, can you tell us a little bit more about the history? I know it's your patient.
Yeah, I'll add two quick things. One is she was referred to me from a podiatrist who was very astute to say that her pain is out of proportion to the duplex he had done in his office. He didn't feel the pulses were weak distally, but he bought her story. So he sent her to me, and we sent her to our vascular lab here, and that's where they really, with the waveform analysis, realized that something's going on in the iliac system. And then we sent her for a CT where we found it. And I think this goes to illustrate that we have to believe our patients. I think she's been bounced around for a little time. I first met her about 4 months ago. So the active smoking is actually what we worked on very aggressively for the last 3 months, and now she's been I should say nicotine or smoke-free for 6 weeks. And she's dedicated to this, and that was part of our conversation or arrangement to say that we'll go ahead and do this, but we really need to try to help you stop smoking first. And she came through with that with a lot of support from her family. So those are just the social aspects to add in.
So can you show the CT? Actually, you know what? Let me show the angiogram. I'm just going to show this shot one here. Can you go to the angiogram, guys? So you can go full screen here, please. So you just go full screen. It's okay. They don't have to see us. So if you see the angiogram here, and I think this is where the conversation should really focus. So I want to talk a little bit about the technical aspect of this. Okay, so you can see the angiogram shows a diffusely diseased common iliac, abdominal aorta distal, with heavy plaquing, which Dr. Farhan showed us on the right common iliac as well. What are the other important features that you guys look for, Vishal, when you see such an angiogram before you decide how to go for an intervention?
Well, I guess the most important thing to look at is the angiographic or the visualization of how the iliac is occluded. The origin, the proximal cap, the distal cap, the length of obstruction or occlusion, and the associated calcification, because we have to determine all these factors that eventually determine what's your success rate, how aggressive you can be, and what other techniques you can use. Here you can see there's almost like it is an ostial occlusion. You see a small beak at the origin, and if you see the distal cap, we're going to show you another angiogram, but you're going to see the distal cap also has a beak. So that's the favorable portion, but the length of the lesion does add to the complexity of the whole lesion. Calcification, you'll ascertain on the CT there was significant calcification, so we have to keep that in mind when we're intervening and deciding the mode of therapy once we cross. So I think the 3-4 factors which we talked about, the proximal cap, the distal cap, the length of the lesion, and the calcification is what determines how to go. And then, of course, how well you think is your better approach. I'm sure PK and Atul are going to talk about going antegrade approach, which is through radial, or trying to grade a retrograde approach through the left femoral axis, which we can discuss in the talk further. So
Atul, you got a CT before you did anything. You had I guess you had a dampened waveform and an ultrasound, and you decided to go for a CT. Is a CAT scan an imaging, or should I say, non-invasive axial imaging? Is that part of your standard care for these patients?
So I think anytime I suspect or I buy the story and I suspect something that I can't see in the duplex, I will scan them. And I think there are probably a lot more severe or CTOs or the common iliac and external iliac than we appreciate. There's a lot more going on, and we're writing it off to other things.
Right.
So I do think it's worth it, especially when someone has a normal creatinine. It's a low dose scan.
Right.
Anytime I see anything abnormal or I'm very suspicious, I'll scan.
How about you, Karthik? What do you do?
I don't do any CAT scan, PK. Based on, I usually go by the duplexes. If I'm very convinced that it's an iliac, and the patient is symptomatic, again, as Atul said, you have to take care of all the other things like smoking cessation, trisilastazole, and everything. Of course, is an iliac lesion, so most likely they won't respond to silastazole because it's an inflow disease. But I directly go for an angiogram and then get to it.
How about you, Vishal? Do you do actual imaging like a CAT scan?
I'll go with Atul because iliac disease, like I said, it's a little bit more complex than doing your straight up SFAs or below the knee lesions. So getting a good non-invasive like a CT angiography gives us a very good anatomical description of what we're going into. So it might help with better treatment strategy to see what I'm going to fix and how I'm going to approach it. So especially iliac cases are a little bit more complex, a little bit more difficult to do sometimes. So for iliac cases, yes. For SFAs and all, the ultrasound and Doppler is very, very sensitive and specific, especially in our lab. So we have a very good visual description of where the CTOs are. But iliac becomes a little complicated. So for me,
so you will do a CT. So I'll ask Dr. Farhan. Sardar, you're about to graduate soon. So tell us what you would do if this is your patient.
The approach with an arterial Doppler duplex is the best first approach as a non-invasive imaging technique. But as Dr. Kukar and Dr. Kapoor mentioned, CT workup would be actually very nice because you can see the distribution of the calcium. You can see how long the CTO is, so you can plan your procedure ahead and already anticipate whether you will need an antegrade wiring technique, an access with antegrade wiring technique, or only a retrograde approach would be sufficient enough. As in our case, for example.
That's a great point. I think so. I agree with Dr. Guja here, and I mean, to me, I would not get a CT. However, I do see the point in what you're trying to say, and I want the audience to see the reason we have this kind of discussion prior to us starting is that there is no real correct way of doing it. Everybody has a logic for what they do, and clearly, I think the advantages of what getting what Dr. Farhan, Dr. Kapoor, and Dr. Kukar are saying is that it's very clearly, if God forbid you have a significant aneurysmal disease here, then at least prior to your CT, so you can plan your procedure and then go on. So generally, I know me and Gujo, what we generally do is we get an abdominal ultrasound. Once we've identified monophasic flow, if the abdominal ultrasound doesn't show a AAA, then we'll go ahead and do just a regular diagnostic angiogram from the left with a 4 French catheter. So in this case, when we do a 4 French catheter, then we identify what we generally have. So these are all great points, and I think to take home for the audience is that you need to have some non-invasive imaging prior to this, and you need to have some logic to your approach. Everything that was stated by the three physicians here, they all said the same thing. They want to plan the procedure. They want to not have any surprises when they get in. They want to understand the access points and the equipment that they may need in order for us to work. So it all depends on your comfort level and how good you are in terms of what your decision is prior to starting. So let me ask now. You have a CT, okay, and now you said you want to plan this. So in this CAT scan, which we have an image of, but not really a good one, I'll put this one up. Say this is your CAT scan. Let me just put this up right here. Hold on, I'm going to freeze it in a second. And I'm going to ask Atul the question, and then Vishal. So Vishal, Atul, so in this CAT scan, say this is your CAT scan. I know it's a very poor CAT scan, but say this is a CAT scan, right? What is it that you see that's going to help you plan the procedure in terms of specifically access and equipment?
So I think I'm going to take one step back and say there's one other important thing. I think when you prep a patient to say that you have a common iliac artery occlusion, you draw it out, you give them the setup, you let them give them the understanding that ahead of time that you're walking into a procedure where there is an alternative. And a fem is not unreasonable here. So we discussed the alternatives because I knew what we're getting into. And I think if we had a 90% common iliac artery, I would say, look, this is a pretty straightforward, much more simple intervention, I think, when you have a CTO of the TIA. So I use that information, I think, to give the patient a more better assessment of the risk of the procedure, as well as talk about the complications or alternatives and things of that nature. If it was not a CTO, I honestly would say, yes, you can always do surgical, but endovascular is a very straight shot. And we expect a very, a complication rate that's so low that I think it's reasonable to go this route. In these cases, I think if you speak to vascular surgeons who can do both kinds of interventions, they'll say, well, look, this is retroperitoneal space. If you dissect, if you get through, if you perf, it's sometimes much more difficult to control, and this is where you can run into a lot of trouble. Whereas in the CFA, the SFA, popliteal, those are all compressible. Those are not going to lead to massive internal bleeding. So that's how I like the CAT scan. But I'll be honest with you, I did not even think about an abdominal ultrasound. I didn't realize how good they are here, and that's something I'll probably
they're very good in general.
I'll try next time.
Yeah,
like
no, it's fine.
But
how did it help you plan? I mean, in terms of access.
So from this point of view, when I saw on the CAT scan, you do see the nub of the left common iliac artery. So my initial approach, although I think we're going to talk about the approach now, was actually to do bilateral femoral, but also get left radial access, because I think an antegrade approach would be nice in this case, and I think putting a multipurpose down, pointing it right in there, you'll get a good push from the left radial system, and you'll be able to go through that way. And I kind of like that sense that you can come both ways, but I don't disagree with going bilateral femoral to start and having the potential to go left radial if you need to.
Got it.
That's how I changed my mind. I would have started with the left radial, though.
Got it.
So what would you do?
I think CT helps in plan. In this case, you have enough room to go femoral accesses, because femoral gives you more flexibility to using larger devices with more safety better. So it gives you more approachability. So here we know where the takeoff or where the distal end of the common iliac or the reconstitution is. And because we know we have enough length to put our regular sheets up there, like a 25 centimeter bright tip sheet or a regular sheet. So, and we have a favorable beak. So my approach will be to go retrograde and try to connect the dots. You can go antegrade, but like I said, if it gives you a little bit less restriction in using your balloons and stent, you have to, because you have to use a long RP sheet, a 6-7 slender. It's a female, so then it spasms and all those issues add into the whole picture, even though you might have a long sheet. But my approach primarily is to try to go femoral access, try to connect the beak, where in this case is favorable for us, so hopefully we'll be able to connect it. And of course, it gives a good visualization where the external iliac is coming through. That's one of the more important parameters for me when I'm trying to go an iliac intervention is the internal iliac doing? How's the internal iliac? How is it disease on the other side? Is the lesion side, does the disease involve the lesion side of the internal iliac? Do I have to cover it, not cover it? That's one of the important factors I'm sure you're going to consider once you start doing intervention of the disease segment.
PK,
so that's where the CT I would probably
PK, before we move on, I just want to know, like, I know the CAT scan we had there, right? We were talking about calcified iliacs. Based on this angiogram, would you still think it's very calcified, or?
I mean, I'll do a dry cine run here. It is generally calcified. I mean, it's not that it's not calcified. I mean, you can see here. See, I'll just do a dry cine.
Because
so
I
you do
I
have some
see
calcium.
some calcification, but
yeah, but you can see the aortic shadow.
Yeah,
I mean, I don't know how it's showing through to you guys. It's calcified.
Okay.
But but to keep going here, I mean, now Sardar, a question for you. What are the views that you want before you start this iliac case?
I would, since we are going on the left side, very important is to line up the internal and external iliac artery on the ipsilateral side. So we have to go a contralateral oblique, which is now the LAO. 2025. RAO. 2025 would be enough for this case to line up the.
So that's a great question. So I know Gujo would also go bilateral common femoral access. So the logic here for us is very, very simple. Ray and I have done tons of cases like this, and the point is, I really believe that your bailouts you have to think about before you do anything. If you have access from a radial with a 6 French sheath, you have no bailouts. You have absolutely no bailouts coming up and down. And I think in these kind of cases, if you can cross from below, or if you can get close to the iliac, reconstitution from below, you can do advanced reentry techniques, and then you might be able to cross should be able to cross. Favorable things to crossing are obviously long external iliac, what's it called, no blunt occlusion, tapered tip, as Dr. Sardar pointed out yesterday on the CAT scan, bilateral tapered tips, and that'll really help. And the views are really going to help. So I just want to show you what we've done so far, and we haven't done anything, but I just want to show you here. So basically we got access on the right side, and then Dr. Sardar and Ray got access on the left side using fluoroscopic guidance. Obviously, you could use ultrasound guidance if you want to make sure you get the common femoral. Very clearly here, we just was very easy to get with fluoroscopic guidance. And injecting from above on the roadmap, we were able to get in. So once we got in, we did a picture. You can see you have a very beautiful beak of the iliac obstruction on the common on the left side, and it looks like it seems to be a blunt occlusion in the AP view on the left external iliac. And then you can see here, if you go to a different view, and this is what Dr. Sardar was talking about, you can see that you have a nice nubbing. See, so that nubbing is very, very favorable. Once you have a beak like that. Go ahead.
Both the beaks look very favorable, right? To enter. So
absolutely.
I think to enter and exit, I think both the beaks look very favorable. This is the most favorable kind of a CTO you have, right? Both concave on both sides. This is perfect way to cross from below, actually. I think that's
right.
That's one way to say, like, bilateral femoral access is better.
So what we decided to do was take a steerable catheter and bury it in the beak. You can see here you have a nice little steerable catheter buried in the beak there, and then just go ahead, and now we're going to go ahead and get
PK,
what
wire are you using?
Well, I don't want to say what I'm using. I want to ask everyone here what they would use, and then we'll take it from there. Go ahead, Atul. Give me one wire, your first wire of choice to start.
I would start with the V18.
Okay. Vishal?
I'll go Confianza.
Karthik?
I would start with Confianza. I always start with 014, but Sardar, what would you start with? Because you're going to be an attendant.
Now, since all of you agreed with Confianza, so I'm biased.
No,
so
it doesn't matter.
I mean, something different.
No, you have to. Yeah, you say what you would start with. So
I mean, if it's not a CTO, we can go with a glide wire 035. But since it's a CTO, we will need a specialty wire, and Confianza 12 followed by maybe Astato would be actually a good approach. Yeah.
So I think those are all good points. The only thing I want to point out to everybody is that you definitely don't want to start with a glide wire here. Glide wire you tend to dissect. I'm just going to have Vishal give me a little dye from the bottom. Just a little dye. Now, I just want to make sure I'm not buried in the wrong area. So you can see my steerable catheter. I'm just going to steer it the other way. So the system has to be straight. That's the key, right? And you want to try to go the other way. See, now you see the confianza is going up. So I'm not going to advance my catheter yet. I'm going to have Vishal give me some dye from above.
You want to bring the catheter a little bit down, PK? Or?
See, look, we're already there, right? So I'm just going to go AP, little dye.
I think we
so the
went
key
through a
is,
little bit,
well, we're in a little dissection plane here. So what
Yeah.
I'm going to do is I'm just going to go ahead and I'm going to try to get more favorable. I've just created an 014 channel and nothing more than that. So when I get the 014 channel, I'm going to have, there you go. Okay.
So
okay,
Vishal, let's talk about
right
Vishal, by the time PK tries, I think let's talk about escalation of wires. Vishal, how would you escalate your wires?
Above.
What I would do is 014, like we started with confidence, and then like how Sardar said.
So
go
ahead. I just want to tell everybody technically. So now I feel like Karthik says a little more favorable in my thing. So I'm going to start advancing my catheter, and just like below the knee, you're going to have a lot of hibernating.
That looks very favorable. Right?
You're going to have a lot of hibernating stuff. Right. So I'm going to do a little roadmap from above here. So once I have my roadmap from above, I don't need to torque. It should be okay. It's torquing well. So I'm just going to pull back a little, and then see whether we can.
So Vishal, you were saying you start with, and you would go to V18. You go to an 18 wire or directly to a glide wire?
No, I usually escalate it. I'm just go slow on it. So
I'm so sorry.
No, I'm good.
I hope I didn't hit you.
We just escalate to an 18,000 of a wire. So either use an Astaro 30 or use a V18, and then last stage, of course, to escalate to an 035 system. But just going back to Atul's approach on the antegrade access, what I would, even if I try to cross the lesion, that's again my personal opinion. Everybody has different ways of treating a lesion. But even if we go antegrade access, I would still try to work from retrograde, so that like PK talked about, salvaging and making sure you have bailout strategy.
Right.
You can cross antegrade, but we can obviously snare and do other techniques. So I would, after crossing antegrade, if we have to, probably still work in retrograde fashion just to be on the safer side.
So you don't want to just push the wire through, which is very important. See, I was not happy with the way the wire was behaving, so I changed my trajectory here, and I think this may be bad again. So I'm not happy with this.
Atul, how would you escalate your wires?
I mean, since I jumped to the 18 already.
There you go. See that? Yeah, look at the way the wire moves.
I'd go
so
back.
I think what's important is you saw how many times I changed the wire, right? And I think I'll change my trajectory. You cannot pierce that cap till you feel you're in the right area. And it's really, honestly, it just becomes a feel thing, right? So you want to go ahead and try to get it through. There it is. Okay. Hope I meant.
Still want to come off.
Oh, no, I just want to. Yeah, that's better.
Yeah, there
okay. Now we're definitely in. So it's very important for you to be able to enter properly and very quickly. And so now when you're in, now you want to make sure, don't be cocky. Take out your stuff, look at the pressure, and then decide. Dr. Sardar had his Wheaties today. He made this so tight that...
So PK, I think just to reiterate your point, the reason why you go bilateral femoral access is when you're doing the common iliac CTO, on the other side you have access to put an aortic balloon inflation if anything happens. Is that it?
Exactly, and now you see you have both the waveforms now. You have an aortic pressure, which I already hooked up, but that's okay. I already hooked it up. So we have an aortic pressure, and you can see the aortic pressure matches the femoral pressure. So now you're very, very confident that you're in. Nice. And now if you want to even do more, you can do a quick aortogram through your end-hole catheter with a hand injection, which we'll do right here. Ready?
All right. 1 second.
Go ahead, inject. There's your aortogram. And you pretty much entered where you should. So now what we're going to do, now we enter right at the cap. And I think, I don't know if the audience was able to see when everybody was talking about wires, what you really want to do is this. So I want to ask the logic of everybody's wires. So Karthik, you and I know why we like our wires. Vishal, we know. But Atul, tell me why an 018 V18.
I found that when I'm going through any kind of CTO, I like to probe with something a little softer.
Flora, let me just.
And I think when you go to a Astaro 12, Astaro 30, or Confianza 12, you're really hitting it with it is an 014 wire, so I think you're safer, but you're hitting with something much sharper. Right. So I kind of like to see the feel of the glide first, but I do agree with you. It does dissect more. And I think in this case, had I come from the top, if I'd come antegrade, I would have come with an 014 system.
Right.
I will step back and say one thing though. Even if I came left radial, I would have got bilateral common femoral axis. And I think, Karthik, you really mentioned the right thing. The biggest fear of this case is the perf. And if you have a perf, you need to throw a coda balloon in the aorta, and that means you need femoral axis. You need it from the other side. And that's the only way you're going to save the patient when you run into that trouble.
I mean, PK is always old school. I mean, because I think that's sometimes the right way to do it, because when you're doing CTOs, you always have to have bailout options. No matter how good you are, complications do happen, and I think you have to be ready for it. If you're radial, you're just not ready for it. The amount of time you spend on it by getting access in that pressure time is more higher. So PK, we look like we went from a little bit of side, but I think it doesn't matter, I guess, at that point of time.
There are so many micro channels, I guess.
No, but you know what? In this view, it looks side, but you know, I think in the other view it was AP. I think we're okay. And the most important thing is, I think we're okay too. So that's why I did this picture to demonstrate the point of entry. So now we're going to get a 7.0 balloon.
Yeah.
So I think
7.0,
40.
Yeah, 40 is fine. Don't you have longer? Don't you have a 7.060 balloon? Any balloon is fine.
Atul, now that we crossed, what would you do?
So I'd actually go with a 5.0 balloon. I'd go smaller. I think I'd like to just have a low pressure 5.0 balloon. Let me open it. Let me see what I'm dealing with.
Okay.
But I know that eventually I will end up with a bigger balloon. So I may be wasting a step, but I always like with my CTOs, I always go smaller when I initially open them.
PK,
well, I mean, I agree with Atul, but I think in this situation, I mean, you already crossed. Once you balloon, you perf. Whether it's a 5.0 perf or a 7.0 perf doesn't really make a difference. Right. So I think that you know, you have to be ready with your bailouts. So at this stage, you know, you have a balloon. You know where you entered. You're going to watch the balloon expansion, and then you're going to decide what type of stent to use. And I think that's the situation. Right now, our ACT was 260.
PK,
we're going to check an ACT now.
You're using a 7.0 balloon?
Yeah, we're using a 7.0 balloon.
Okay.
Which is normally not what we do. Karthik and I and Vishal generally go with a 6. But you know, we decided today to be a little adventurous.
Okay. All right.
Yeah,
and of course, we're using heparin on
little
the case.
dash.
Yes.
I think this is one of the cases you would I know we use a lot of Angiomax here for our peripherals. Obviously, this is
PK, I know you are an IVUS provocator, but are you planning to do IVUS here?
We may after we do this. I just think that at this situation, the 014 or the 014 wires, I don't feel like losing my wire position. What happened to my pressure? Oh, you're going to. Oh, he's getting ACT. Yeah, so that's the reason I didn't go with an IVUS.
Vishal, would you do an IVUS here? Or?
No, not. I mean, I don't think IVUS is going to give me any more information. I mean, here we were. Even if we were, our wire responded very favorably. So I think even if we were maybe a minimally subintimal, but that's not going to change my. That's not going to change my treatment strategy once.
Okay.
So I think IVUS is not going to give me much information here.
I'm assuming none of you guys want to do. Atul, do you want to do IVUS or
go up?
I think at this point, no. I think you're crossed. You have very good wire movement at the tip. We saw how we crossed. If so, the IVUS would show what? Your intraluminal or adventitial. I don't know if it makes such a big difference if you have a micro dissection. So I don't think there's a downside to doing it. Let me put it that way, though. Like, what are you gonna? You're not gonna go backwards by doing it. But I don't think it's a necessity.
Oof.
So,
nice.
Wow. Okay.
You saw that.
Did she feel anything? Did the patient feel anything?
Yeah, she's moving slightly. But again, that's very important to remember.
PK the reason I asked about IVUS is, so I'm assuming all of you guys want to go for a covered stent here, right? That's why.
I think 100% we're going for the covered stent.
Would you ever choose a bare metal stent?
Okay, down. I just want to watch 1 second, Karthik. Just watch her pressure.
So Vishal, what are we watching for here when the inflation happens? The dissipation
mainly
symptoms?
looking for
a little bradycardic now.
The patient responds, the pain, the bradycardia, the hemodynamics.
So right now the blood pressure is dropping, but it's okay. It's around 120 stable. So her heart rate went up when she was in pain and then dropped down. So we're just gonna take a quick picture here.
Off.
No, you don't need DSA. Okay, you can do it. You can do it.
Okay.
I don't think it makes a difference. She's fine. Because if she had perfed, it would have precipitously dropped.
Yeah.
Yeah. So we're good.
Nice.
So now you can see, Karthik, the 7.0 we opened, but it recalled right away.
Right.
So I think in this situation, I'd probably go with a I'm going to check the distance to my internal iliac now to look at my stent sizing.
So Vishal.
Bad dissection.
Yeah.
Where's my internal? Internal is gone.
Hold on.
I think it's still there.
Nope, it's down
still
below.
there.
No,
Let's take one more.
that's the ureter. That's the ureter. No,
There
that's
it
the
is,
internal.
right
All right,
internal.
so this is a 40? 60 balloon, right?
60.
So give me a 7058 VBX now.
So
So I want to go with the VBX.
So PK, you are planning to come across the internal, rate,
I
stop at the internal?
I think I'm going to try to stop at the internal, and if I have to use a non-covered stent distal, I will,
Distally you
Karthik.
would,
But I think
okay.
at this situation, I think it's more important to get this artery open.
Okay. Okay.
I didn't like the way this expanded. That's why I'm keeping the balloon there till I get my VBX ready. Because sometimes if you perf, the balloon can hold tamponade it. I just didn't like the way there was a sudden pop as
Right.
I felt it in my finger as we went up. So therefore at this stage I may just put the VBX in and then see how she does. So he's going to get the VBX. So
And I think we talk about, would you
there,
come
right?
up, would you come up the other leg and would you do
7058. We don't have it.
kissing stents bilaterally? Or
Okay.
are you just going to try to nail the left side?
Both can go up.
I think
What are
we
your
get.
thoughts on
But
that, Karthik, while we're getting the
is
stent?
she okay, Chu?
Okay. So the plan here is not to do any kissing stents because there is no other side disease clearly, but nail the ostium because there is a nice
Yeah,
nub.
120 is.
I'm sorry, buddy.
No, I'm saying it's the goal is here is to nail the ostium, right? Because there is a nice nub, so I think we can nail the ostium.
And I agree. I think that's one of the thought processes though is if you're that close to the ostium, you have to make sure you get
Didn't
it.
I ask for
Because
the
if you don't, then you need
7058?
to have
Are
the
we
other
sorry?
stent come up the other leg.
That's all 8os.
So it looks like she's
So
holding up the pressure. So as
Yes.
Vishal was just mentioning, we are looking for bradycardias. Again, any vagal responses as we are talking about. Vishal, anything? Would you use a bare metal stent? Just to throw it out loud.
I mean, not really, unless you have residual disease distally.
So why don't we? That's a great segue to stop. Because I think Dr. Sardar has prepared a wonderful lecture
perfect.
for us.
That's great.
And while we are getting the stent ready, we may deploy it's just a balloon expandable stent, but we'll save it, and or maybe you can put us up in the corner while Dr. Sardar talks. So this way we can go ahead and learn something from him while we're doing the procedure. Go ahead, Farhan.
So next slide, please. This is the task classification for the aortoiliac PAD.
One second, Sardar. Can you put up our angio on the corner somewhere? You can block him out. It's okay. He's good looking, but not that good looking. All right. Thank you.
I'm in mask anyway.
Good. Let's walk it out. You can put up our angio.
Can we put up the angio, please? Yeah.
He's good looking and married.
No, but we need the slides on, guys.
We need the slides too, guys. We need everything. There. Can you center it now? Get rid of the hemodynamics. There you go. Oh.
No, we can take off Dr. Farhan. Sardar doesn't need to be seen. That's according to PK.
Chu, she's moving.
Okay.
Hold on.
So we use the task classification to determine whether an aortoiliac disease is deemed as complex or less complex. So from A to D, and D is the most complex, which is mostly suitable for surgical treatment. So next slide, please. We have our ACCHA guidelines published in 2017. They give us a class 1A recommendation for treatment of aortoiliac occlusive disease after failure of medical therapy and supervised exercise therapy. Next slide is the appropriate use criteria, which were published in the same year. And they give us also a recommendation regarding patients with claudication, Rutherford class 2 to 3, and appropriateness of 9 for those patients who have aortoiliac occlusive disease with over 50% stenosis or a translesional gradient of more than 10 millimeter mercury. After failure of pharmacologic or supervised exercise therapy. For those who didn't go for this medical therapy or supervised exercise therapy, the appropriateness drops to maybe appropriate to 6 and 5 points. Next slide. And once we approach a CLI patient with Rutherford 4 to 6, the appropriateness is always present, even if there is no previous medical therapy or supervised exercise therapy, since it's a limb salvage procedure. So next slide, please. Regarding technical considerations, access, we discussed it lengthily, bilateral femoral access like in our case. There might be also a possibility to get a radial access or a brachial artery access. Angiographic views with contralateral oblique view is very favorable to line up the bifurcation of external and internal iliac. Use of the sheath size, in our case we use 7 French, is actually the minimum for delivering appropriate stent sizes. And anticoagulation, we prefer using heparin since it's reversible, and we use an ACT 250 to 275. And some people might use bivalirudin. This was associated with favorable outcome and good safety. So with regards to lesion crossing, as we explained, if we are handling non-occlusive lesions, we can use hydrophilic coated glide wires over an angled support catheter. But since we are approaching here a CTO, 014 and 018 platforms with specialty wires with CTO wires like Confianza 12 or Astato 20 might be the good start. Over microcatheter or support catheter and exchange once we cross the lesions for a more supportive wire and 035 platform, like a supracore in our case. So next slide,
not to move, guys.
In case there is difficulties to cross the lesion, there are crossing devices and re-entry devices which are mentioned here: the front runner, Viance, and Ocelot, and Outback, Off-Road, and Pioneer. Next slide, please. With regards to imaging, we talked about intravascular imaging. It's there is a Japanese study showing that treatment of our aortoiliac occlusive disease with IVUS guidance showed a favorable 15 years primary patency of around 75% and a secondary patency of 91%. Showing that, and it's very important in this figure below, you see that this showed using IVUS in such cases made also complex aortoiliac disease with high patency rates. Next slide, please.
Ready? Sorry.
With regards to the therapy, PTA we start with balloon angioplasty with nominally undersized balloons to avoid perforations and dissections. We can estimate also the degree of calcification while inflating the balloon.
Repeat ACT.
We do slow sequential upsizing of balloons. This is highly recommended, and we avoid over expansion of the balloon once the patient complains of abdominal pain. Next slide. Is regarding plaque modification with cutting balloon and scoring balloons. Those are mainly used for ISR lesions. And there is now a new technology called the shockwave intravascular lithotripsy, which is now being investigated in several randomized studies. But there are already reports in the literature using intravascular lithotripsy to facilitate large bore interventions like TAVR or TEVAR, like published from a group in Copenhagen recently in CCI. Next slide, please. And finally, we have to talk about stent selection. And here we have a huge variety of stents from self-expanding, balloon expandable stents and covered stents. And also those covered stents, they have self-expandable and balloon expandable platforms. Next slide. All of these stents, they have pros and cons, and for example the balloon expandable stents, they have high radial strengths which makes them very precise in deployment, and they are suitable for ostial or bifurcational lesions. They give, unfortunately, they have a higher propensity of dissection or perforation and plaque shift to the contralateral iliac in case of a bifurcation disease. And the self-expandable stents, they are flexible. They have, as a disadvantage, lower radial strengths, and the advantage is that they have a lower perforation risk than the balloon expandable stents. They are not suitable for precise deployment, and they cannot be post-dilated over their designated diameter. And finally, the covered stents, they are very, very good to exclude aneurysms and to prevent neointimal growth into the stent lumen. Unfortunately, they are not suitable for bifurcational lesions because they will exclude the side branch, which, like in our case, we would not use. We would not have used the covered stent if we had to cover the internal iliac artery as well. So next slide, please. There are some studies. There are many single-arm studies and many prospective registries, but there are few randomized trials comparing these techniques, balloon expandable and self-expandable stents. The ICE trial was published in 2017 in JACC Intervention. Included Rutherford 1 to 4 claudication patients with a single significant over 70% lesion estimated by Doppler ultrasound and the lesion length of 10 to 200 millimeters only. The aorta and the common femoral artery had to be healthy in this case to be enrolled in this trial. The comparators were the VisiPro and Protégé stent, balloon expandable and self-expandable stent, and the primary endpoint was binary restenosis at 12 months estimated by Doppler ultrasound. And the results are shown here. The primary patency at 18 months was in favor of the self-expandable stents over the balloon expandable stents. Similarly is the figure on the right side. The freedom from TLR also in favor of self-expandable stents. And in this study, they performed a logistic regression analysis showing that independent predictors of restenosis was first the stent selection, unfavoring balloon expandable stents, and lesion type with instant restenotic lesions being a higher risk for restenosis again. So next slide, please. There is another study, the mobility study, which was presented in at the SKY meeting in 2012, comparing the Absolute Pro and OmniLink, self-expandable and balloon expandable stents from the company Abbott Vascular. And here they compared the major adverse events at 12 months, showing that TLR rates are similar, comparable in both stents. Even the restenosis was comparable and freedom from TLR. And the functional improvement was significant in both groups, comparing baseline to follow-up assessment. Next slide. Now, with regards to covered or non-covered stents, there is also one major trial which was published in 2011 in the Journal of Vascular Surgery, the COBEST trial comparing covered stent is the Advanta V12 balloon expandable covered stent, and with any commercially available bare metal stent. Inclusion criteria was more wide than in the ICE trial. Here they allowed task B, C, and D lesions, and also those lesions who were hemodynamically significant dissections and recurrent restenosis after balloon angioplasty. The primary endpoint was a little bit different, assessed as in the ICE trial. As you can see, defined as only 50% reduction of lumen diameter, estimated by Doppler ultrasound or CTA or digital subtraction angiography, and at 18 months follow-up. So the next slide, please. In the 18 months follow-up, they found that the covered stents have a higher freedom from binary restenosis, so this trial fulfilled the primary endpoint. And on the right side, you see the subgroup analysis showing that covered stents are favorable in most subgroups, especially in those with higher complex lesions with task C and D. This trial also published in 2016 a 5-year follow-up study with primary patency and secondary patency rates. Here you see the two figures for the primary patency, Kaplan-Meier curves for task A and B in the top and C and D in the bottom, favoring again covered stents over bare metal stents, and the secondary patency rates was also favoring covered stents. They found also predictors for primary patency. In this case, there was the stent type selection and the Rutherford classification, which were associated with a higher or lower primary patency rate. So now I'm coming to my last slide, please. In summary, endovascular iliac artery interventions are increasing, including more complex lesions nowadays. Careful case selection, workup, and planning is mandatory to achieve maximum success. Despite reported safety of bivalirudin, we recommend heparin as a preferred anticoagulant. And various stents are available for different lesion subsets with favorable long-term outcomes. Thank you very much.
Fantastic presentation.
That's a very nice presentation for that.
So based on what Sardar did, I think we did the right choices based on the data. I don't know, he'll critique us. So I just want to go over what we did. So we went ahead and we placed the stent. I think there's a couple of good teaching points here. So while he started, we left the balloon up, took a picture. Everything looked to make sure there was no perf, and I think that's important to make sure if there's a perf, you can go right up with the balloon. If you see here in this view, and this is I guess an AP really view, you can see that the stent almost looks outside the lumen, but what's important to remember is that you have a lot of plaque there that's recoiled, and it's probably pushing the stent to one side. So took another picture, it looked a little bit better with us, and then we decided on the stent placement, which we felt this is probably a good spot to place the stent if it's slightly higher than we initially anticipated. But remember that the peripheral stents are really not made like the coronary stents. There's always an overhang of the balloon from the stent, so you have to anticipate that the dot should be higher than where your stent will be. And here you can see the dot is higher than where the actual edge of the stent is. If you don't watch that carefully, you will miss the ostium 9 out of 10 times. So after we did that, we took a picture. She had some amount of discomfort, I'm not sure. So then we went ahead and took a picture here, and you can see she's moving with a little bit of discomfort. We went to nominal with a 7059 VBX stent, and then we took another view here. Actually, she was moving again, so we asked her to stop breathing. Again, she's moving, and then we finally, that was it. So then we went ahead and took a picture, and you can see here that we pretty much hit it right at the ostium. And I think it's important, the little dot trick is very important. If you don't watch that dot, you may actually land it below where you want it to land it, and I think it's very important here. And you can see you have good apposition, at least angiographically. So at this stage, we went ahead and checked the distal edge, which is also very important. And here we had a little bit of discussion. I was a little concerned that the occlusion was a little lower to where the stent covered, and I think this is where good preoperative imaging is important. So we went back to the first picture, and you can see here that the actual occlusion is higher and the bifurcation is lower. So then when you go back here and then you take a look, you can see here that the occlusion is our stent covers below where it was occluded, and I think we're very happy here. The only question is here to post-dilate or not post-dilate, and I think this is a very important take-home point. Can you show us the tracings, please? So if you show us the tracings now, you can see here that all you're looking for is hemodynamic relief of your obstruction. Okay, so now if you see here, you have a sheath in the external iliac artery, like where you see it. Mm-hmm. Then you have the common femoral or the aortic tracing, which is red, and you can see you have absolutely no difference in your tracings. So at this stage, you took completely occluded iliac and gave her a 2 millimeter gradient. I think the enemy of good is better here. So I think we're going to stop. And I just want to ask Dr. Kukar, Kapoor, and you, Dr. Guja, to talk about what you would do for surveillance of the stent and how would you survey a covered stent.
All right, Vishal, you want to start? Go ahead.
I mean, I would clinically follow the patient, get an ultrasound Doppler as baseline post-intervention to see how the velocities and the waveforms look on the side of the lesion, and then clinically follow the patient up and get a serial ultrasounds first in the 1 month and then 6 months and onwards to see how.
So how would the ultrasounds help? You're not going to be able to see within the stent.
No, I understand, but it's mainly the change in the velocities and it's like an indirect marker to see the change in the velocities and the waveforms itself of how it responds. I mean, I'm not going to get this personally, would not send her for surveillance CTAs. I would probably just follow her clinically and most likely, if need be, ultrasounds of the leg to see if there's any change in velocity, let's say in the common femoral or the waveform blunting, which might suggest some proximal worsening of the stuff itself. Usually, because it's a big vessel, the chances of instant restenosis are much lesser than it's a smaller lumen. But again, things do happen. We do see a lot of stuff.
So I pulled the sheet back, and I think that's very important because you can see that there's another gradient in the external, and I think this is how you're going to make them feel better or not feel better by identifying these kinds of gradients. So let's take a picture here. So the question is, where is the stenosis? Because there is clearly a gradient.
Okay, let me zero both. Hey, let's
Zero both guys.
Let me flush and zero. Give me 1 second. I got it.
So I think right now you have what is it, 20 millimeter or so gradient.
Zero.
We may just watch her, see how she feels. Zero guys.
Zero both.
Okay, we're zeroing both.
Mm-hmm.
Excellent.
Now zero.
Now it should be okay. See, the oldest trick in the book is not true. So clearly there's a gradient. Ready? Let's take a picture.
You want to take from above and below?
No, just from below. I bet you it's across that internal.
Across that,
Step
internal
down.
iliac.
Whatever. Yeah, the lesion.
So I think at this stage, we've relieved her. I mean, Artie's going to follow her. She may or may not feel this as she had a 90 millimeter gradient before. We could stent it. I think you have open cell stents that we could clearly use. That would protect the internal. You're right here. So I'm going to leave it up to Artie to decide what he wants to do here.
I think with the 20 millimeter gradient, we could put a
stent,
yeah,
right?
I
yeah.
agree.
I think we should fix it.
All right. So give me a 10-0 or actually give me a 9-0. 9-0-30 stent here.
PK, let me ask you a question. When you put covered stents like this, right? They are like any other endographs, right? They are endographs. Are you concerned about? I mean, clearly the concern is not type 2 or type 3 leaks, but are you concerned about the type 1 leaks if you're not properly opposed?
I mean, it's so rare. I mean, I think you would see something if it was going to happen, you would see it now.
30.
So I think that's why if you remember, I took a bunch of
40.
pictures.
40.
40's fine. I took a bunch of pictures, but what I'm going to do here is
PK, I think it's more than PK. I'm sorry. I just want to let you know. I think this is more than 40, right? This is you have to come way down on the external because when your sheet was initially there.
Yeah, I see what you're saying.
Yeah, because when your sheet was there, when the gradients were equal, right? So your sheet was way above that distal proximal kind of external iliac lesion. So I think it's much more than 40. It's probably 60 or 80 actually.
Yeah, it's just about 20 millimeters, 120 to.
Yeah, so your sheet before when.
So what we can do is we can balloon angioplasty it and then decide whether we get rid of the gradient or we can. You know what?
Yeah.
Give us a stent. Let's stent it. You're
so
right, my
because
sheet came way back.
Yeah.
Or I could always do it with a sheet again.
I was gonna say you can all you do is put the sheet back up and then you're gonna know where the gradient goes.
Yeah. So it's not there. It's here.
Yeah. So it's more 80, right? So you have to completely come across to that level.
I'm thinking we should leave. I
want to leave it?
I think we should leave it. I mean, it's already getting better. It's 123, 136 is the 15 millimeter gradient.
I know, but you still have a 20 millimeter gradient, though, PK. So I mean,
since you're already in there, I guess we just fix it and give it a good result.
If you're doing it, you might as well just fix it.
Yeah, I know. That's what I'm saying.
960.
That's what I would do.
So we're going to put a 960 across it. So let's talk about the value of this internal iliac because I think it's very important to talk about. So what do you guys think about the value of this internal iliac?
I mean, my theories are you keep them every time you can, but you have a contralateral internal iliac that's patent, so you're not going to run into trouble if you have to cover this. But I always try to keep it. I think there's a lot of syndromes and pain and discomfort or issues that we don't appreciate as much. My theory is keep them as much as you can.
PK, what would you say?
I mean, I don't mean to be sexist. I have 2 daughters, but I think it's a little more important in a man. But I really think that I think that I'm going to do this overlap. You can deploy it here. You're across the box. You're way in, so you can deploy it. Yeah, you're good.
This is a 60.
Yeah, that's okay. Little overlap is nothing wrong.
Deploying now.
Well, this looks much longer than a 60, though.
Yeah.
Are you sure this is 60 or 80, PK?
Yep. No, it's 60, bro. Walk it out. It's okay.
Because when I look at the tape, right?
Already gone. Walk it out. Walk it out.
Because I'm looking at the tape, this looks more like 80, but that's fine.
Yeah, the tape can be deceptive.
Damien, last I heard, he passed math in school, so it should be okay. So let me have a balloon, Damien. Give me a 6040 balloon.
All right. So Vishal, what do you think about the internal iliacs?
No, I mean I agree completely with Atul. Keep it. I mean it's there for a reason, so try to salvage it as much as you can. You always have a contralateral.
I took a survey of 100 people. They wanted to keep both their internal iliacs.
That's as explicit.
They said, I asked them, would you like one or two? They said, can I have two? I said, okay. So yeah, I agree with these guys. You got to keep your internal iliac.
That's right. All right. So that's the common consensus. Even that's my consensus. So PK, we were talking about the leak, right? So a position and
yeah,
the leak.
you know, I think when you have a type 1, you see it right away.
Right.
And that's why I'll ask Vishal as soon as we balloon this, just to go over it.
But classically, you don't see type A for a couple of. You don't see type A is not like immediately seen, right? So.
No, in a graft, but this is not an endograft, right? So in this one, you have a totally occluded vessel. If it was going to leak right away, you would see it. I have never had a type 1 endoleak in these kind of stents. Obviously, if it does happen, it would be catastrophic because it's not an aneurysm. So that's why I think you have to really watch this before you're done. Go to 8. There's 8 down.
Contrast.
A little bit of discomfort,
so,
as we would expect.
Right.
Pull back, go up again.
So would you IVUS it to size and see perfectly, especially if you're stenting at the level of the ostium of the common iliac?
No.
Okay, 8 down. I think, like I said, the IVUS issue for me is a question of losing wire position in a CTO. I'd go up here again. I was very uncomfortable about losing wire position.
No, after
CTO.
stenting, I'm saying after stenting. Would you see if the
post-dilate
matching the vessel
down.
size? Yes.
I
think because it's a covered stent, right? So you can actually post-dilate as much as you want. So
I agree with you, and I really think that in this situation, I think in this situation, she would not have had pain if we were undersized.
Okay.
And
right.
I didn't really feel like we discussed, but we could IVUS. We could IVUS this. Walk this out, guys.
I'm just a thought. Vishal, what do you think?
No, I mean I would just probably just.
No, I heard the blah, but.
No, I just said.
Ready?
Just kidding.
Oh, we have the IVUS open. Let's IVUS. Ready?
No, Atul, what do you think?
I think we should IVUS.
I think from an academic point of view, we should take a picture. IVUS it. But reality is, I think you could leave it with the gradient now.
No, hold on. Let me see this.
Let me go from
So I just did from below.
Gone.
I think the gradient's completely gone, and I'm going to have them inject from above and below. Go ahead.
Beautiful.
I think it looks really, really pretty.
I mean, for once I can agree with Vishal. IVUS is not necessary here, but
no, let's do IVUS. Let's do IVUS. I'm going to pull this wire back a little bit.
When you tell no IVUS, PK will do IVUS. If you tell yes IVUS.
Hold on. Fix the balloon for me.
Yeah,
I see it.
You want to see the
No. Is the balloon already up? No, it's not up.
No, not yet.
There
it comes.
Now
you want to see the sheath and the distal part of the stent, PK?
Yes.
Yeah, that's exactly what I want to say. Okay, go up with the balloon slightly, guys.
Give me 1 sec. Going up.
Go up slightly.
You're outside the stent, right?
Down.
I'm doing that on purpose. Okay.
Yeah.
Right.
There you go. Okay. Good. Now let's walk. Let's take this wire up with the IVUS up. I'll take this wire up with the other IVUS wire.
With the
V18.
Spartacore.
That's we have an 018 IVUS.
Because we have about 5 minutes, PK.
That's Sandeep wire.
Okay.
Steel core.
Hold on.
Steel core.
Go to corner. So I'd like to welcome our new AV crew, Med in Box, for us. I think this is the first one they're doing for us. I know they've done a lot for Dr. Sharma. So they've been doing a fantastic job. So it's a great crew to have here with us. So the IVUS is up now. We'll do a quick IVUS. And I think this is good. And I think there should be more intravascular ultrasound done in endovascular, although we're kind of working on some algorithms on how to interpret it. Currently now, I think it's very good for vessel sizing. It's very good for these kind of cases where plaque morphology. So let's see what the IVUS shows.
Plaque burden.
So really, the only way you're going to be able to tell is, the aorta in, and that's it. Okay, ready? Can you
turn the chromoflow off?
Can you make it a little brighter? Oh no, you can see. I can see it. No problem. So there's the aorta. Turn off the chromoflow. Stop it.
Stop recording. Yep. Okay, let me store this. Okay.
Thank you.
All right, start, Damien.
That's the distal aortic plaque that we saw.
Right.
Right. There's your catheter. There's your stent. So let me see. It's obviously hard to see outside the stent, so I'm just going to see the edge.
Right up there.
It's really hard to tell.
Well, at least it covers the ostium. That's the most important thing you want to see.
So it's very hard to tell if we're 1-to-1. I mean, it looks like
you can see the distal sizing. You can see the distal sizing.
Perfect. We're 1-to-1.
Yeah.
Okay. And now we're in the regular stent, and we're out. So I think we're good.
Yeah.
So let me just advance the sheet up so they can change out.
So that's a 7.0 stent you used, PK?
Yep, that's a 7.0 stent I used. Okay. And I think we're done. So let me just do a quick wrap up. And I think I'd like to
that's a great case.
It's a great case. It really was a quick case, a lot of learning. So I think for the people at home, I think it's very important for them to really talk about the approach to these kind of lesions. I think it's important to talk about axial imaging and think about how you're going to plan the cases, and depending on your experience level, you can decide what it is that you want to do. We really demonstrated and discussed access points. We demonstrated the value of axial imaging. We demonstrated the value of different types of strategies, wires, and obviously the use of different equipment. Dr. Sardar went over the relevant data, and I think at this stage, you should all be able to go tackle these cases without difficulty. So again, I thank Dr. Kukar for bringing these wonderful cases, and obviously our entire team, and Dr. Karthik, thank you for coming on time. So we will see all of you. We'll see all of you next week. I mean next month when we do a live webcast again in August. So thank you again.
Thank you for being on time.
All right. To wrap up, thank you, PK and the team for appreciating my timely appearance on this webcast. We would love to hear questions from you guys on the website. This live case will be archived by tomorrow in 24 hours. In our website, and then please do put us any questions, and we would answer it on a timely manner. We would look forward to seeing you guys again next month, August 28th, Wednesday, at 8 a.m. New York time, Eastern Standard Time. Thank you. Have a great day. Have a wonderful week.